Hello and welcome to Healthcare and the ADA, including people with disabilities webinar series. My name is Pam Williamson, and I am from the Southeast ADA Center, and I'm your moderator for today's webinar. The series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information about the Americans with Disabilities Act. You may reach your regional ADA center by dialing 1-800-949-4232. Next slide, please. You may access real-time captioning for this webinar by choosing the CC icon in the meeting control toolbar. To toggle the meeting control toolbar permanently on, press the Alt key once and then press the Alt key a second time. Next slide, please. If you do not have sound capabilities on your computer or prefer to listen by phone, please dial 1-669-900-9128 or 1-646-558-8656. The webinar ID is 837-2204-3591. As a reminder, this is not a toll-free number, and this webinar is being recorded and can be accessed at adapresentations.org website or at adapresentations.org/archive.php next week. This webinar series is intended to share issues and promising practices in the healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modification of policies issues under the Americans with Disabilities Act. Upcoming sessions are available at www.adapresentations.org under the Schedule tab. Then follow to Healthcare. These webinars occur every other month on the fourth Thursday of the month at 2:30 p.m. Eastern Time, 1:30 p.m. Central Time, 12:30 p.m. Mountain Time, and 11:30 a.m. Pacific Time. By being here, you are on the list to receive notices about future webinars in this series. These notices go out 2 weeks before the next webinar and open that webinar to registration. You can follow along on the webinar platform today viewing the slides, or you may also download a copy of today's PowerPoint presentation at the Healthcare Schedule webpage at www.adapresentations.org. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions in the chat area text box or press Alt-H and enter the text in the chat area. So questions will be addressed at the end of the session, so feel free to submit them as they come to your mind during the presentation. If you are listening by phone and not logged into the webinar, you may ask questions by emailing them to adatech@adapacific.org. Next slide, please. If you experience any technical difficulties during the webinar, please send a private chat message to the host by typing in the chat window. Type your comment in the text box and enter keyboard, Alt-H to access the chat box via keyboard keys, or email adatech@adapacific.org or call 510-831-6714. That's both voice and relay. Today's session, ADA National Network Learning, is titled Health Equity and Disability, Impacts of Unconscious Bias and Diagnostic Overshadowing. While everyone has an unconscious bias as a result of our own experiences and histories, biases towards individuals with disabilities can result in inequitable health care and poor health outcomes for these patients. Diagnostic overshadowing is rooted in unconscious bias and occurs when new symptoms are attributed to pre-existing conditions. This can cause misdiagnosis, delayed or unnecessary treatments, and or poor health outcomes. This presentation will review a variety of case study examples of the impact of biases and diagnostic overshadowing on patients with disabilities, how patients' biases may impact healthcare outcomes, and strategies to address and overcome biases in healthcare. Today's speaker is Holly Darnell. She is an ADA coordinator with the UC Health in Colorado, and her role is focused on accessibility, healthcare access, and equity for patients and visitors with disabilities at outpatient medical clinics. Holly, I'll now turn it over to you. Thank you.
Thank you, Pam. Like Pam said, I am an ADA coordinator with UC Health System in Colorado. Our health system has 12 hospitals and over 150 outpatient clinics, primarily in Colorado, but we do also have some clinics in Wyoming and Nebraska. I mentioned this in my role in terms of the fact that I do not handle ADA accommodations for employees, only for patients. And just so you know where I'm coming from in terms of presenting this information, this is a topic that is very interesting to me and one that I have researched and presented within our system to our staff, but it's certainly not something that I would consider myself an actual full-on expert in, as I do not research things like bias and diagnostic overshadowing. So I just want to put that caveat out there that please ask whatever questions you have. And if it's not something that I have the answer to, we'll try to find you an answer. Next slide. Today, we're going to talk about unconscious bias, types of bias, and how bias might work for people or against people with disabilities in healthcare. And then we're going to spend the bulk of the time talking about diagnostic overshadowing. As Pam mentioned, we have some case examples that we'll use to kind of highlight what this looks like when it's in action, but then also spend some time discussing strategies to overcome this, both for providers and individuals who work in healthcare, but also for patients. Next slide. This quote comes from one of the case studies that we'll talk about in a little bit. And I think it really highlights the importance of this topic. This is a patient with multiple mental illness disorders speaking about her experience in healthcare. And she says, I sometimes find myself tempted to leave them, referring to her medications for her mental illness disorders, off the list of medications I provide to practitioners. I worry about how disclosing my medication regimen may influence the way a doctor views me. I almost never reveal I have bipolar disorder because of the stigma associated with that diagnosis. So for those of you on the call today that work in healthcare, you can see how if patients are not feeling open enough and trusting enough to tell us their full medical history, that could impact the care they receive in a variety of ways. Next slide. So we're going to start our talk on unconscious bias with a couple of examples of the way that our brain can automatically fill in information without us realizing it. I have two examples that are primarily visual, one that's an auditory example, and I'll do my best to describe both thoroughly for folks who may not be able to see or hear the examples in full. Next slide. Our first example, you have two faces on the slide. I want you to take a minute to look at them. For most people, one of these faces will appear to be more feminine and one will appear more masculine. As you look at them, see if you tend to gravitate towards one being one of those ways. And then I'll explain the image in just a moment. Next slide. So we have two faces here. Typically, for most individuals, they would say that the face on the left appears more feminine and the face on the right appears more masculine. However, these images are the same face. The only thing that has been changed is the contrast between the face and the skin tone and some features, so that the face on the left that people would typically say is feminine has less contrast than the face on the right that people would typically say is masculine. So our brains have stored information about the way that we perceive these types of features in people, and we use those things unconsciously to fill in when we don't have full information from our visual system. So these images both are only showing faces from about the middle of the forehead to the middle of the chin. We aren't getting any other information such as hair or clothing, jewelry, or other things that might give us the information on a conscious level to assign features to be more feminine or more masculine. In this case, simply changing the contrast of the skin gave us cues on a subconscious level that our brain typically uses to designate those categories. Next slide. In the second visual example, we have an image here, and without describing it too much, because it'll spoil it at first, I am curious to see if you can find 16 circles in this image. When you first look at it, do you maybe see a series of rectangles that appear to be sunken, almost like panels of a door? And give just a moment to look for those circles. Next slide. So this illusion is called the coffer illusion, and it really relies on our brain's nature and experience on what we commonly see to fill in gaps to identify objects. So initially, we might see one representation in this image, and for most people, that's the series of vertical lines and rectangles, because that's mostly what we see more commonly in our day-to-day lives. But once you get some information and some cues to look for the circles, then they tend to pop out and to appear once you have cued your brain with what you want it to look for. Once we see the circles, sometimes we can then go back and forth between the rectangles and the circles and even see both possibilities at the same time. So there's no one right or correct way to see this image because it's inherently ambiguous. We can see both things at the same time, or once our conscious brain knows what we want it to look for, then we can find things that we maybe don't automatically see in the image. Next slide. This is our audio example. I will have the host play it, and then we'll talk about what we gained from this.
So what you'll hear is a sentence, a spoken sentence, that's been transformed by a computer to sound like gibberish. So, any idea what they said?
No.
Okay, you can hear it one more time. Okay, now we'll hear the real sentence.
The Constitution Center is at the next stop.
Does it make sense that time?
Yeah, wait, was that the same?
It was the exact same sentence that you heard the first time.
No way.
It's the exact same sentence. Your brain is always using prior information to make sense of new information coming in. So once you know what the sentence is, when you go back and hear the distorted version, you can apply that information and it makes sense.
So in this example, as they said, we had a sentence that was changed using computers to make it to where you wouldn't know what it's saying offhand. But then once you hear what it's actually saying, if you go back and rewatch this, even after the webinar, you will now likely always hear that sentence in the jumbled version of the audio because your brain has that reference to pull from. Next slide. So how do these exercises relate to bias? Well, first, let's just kind of talk about bias and what it is. Bias as a whole are tendencies, inclinations, or prejudices towards or against something or someone. They can be conscious, the things that we really know about people on a conscious level that we're able to acknowledge, or they can be unconscious, the things that might influence our understanding, actions, and decisions in an unconscious manner. And that's really what these examples were highlighting, is that based on what we have seen and experienced in our world, our brain uses that information to fill in gaps on an unconscious level without us even realizing it's happening. Next slide. So biases are typically described as being stereotypes or prejudices. Stereotypes are fixed, overgeneralized beliefs about a particular group or class of people, while prejudices are unfavorable beliefs formed without basis. They are a prejudgment or unjustifiable attitude of one individual or group towards another. But it's important to note that everyone has biases, and biases as a whole are not inherently good or bad. Some of our biases are hardwired into us through evolution. Things like safety, recognizing animals or situations that pose a risk and igniting our fight or flight response. Others are learned through socialization and a combination of our genetics and experiences. Biases allow us to make choices in an efficient way. They can be adaptive when our decision-making is enhanced by biases, and they can be maladaptive when they cause us to rely on faulty information or they don't generalize to a situation in which we are applying. Typically, prejudices are those maladaptive biases and are things that are maybe formed without basis or applied to groups of people where they don't actually apply. Next slide. So a little more on unconscious bias. Unconscious bias is an automatic mental shortcut that helps us process information and make decisions quickly. This can affect our understanding, actions, and decisions based on attitudes and stereotypes and the way that we perceive those. Again, unconscious bias is normal. Everyone has biases. I'm not here to say that there are people in this world who this presentation does not apply to. We all have biases, and we'll talk more at the end of the presentation on our strategies about what the work we can do to recognize and address the biases that we might have. And similarly to just bias as a whole, unconscious bias is not always a bad thing. Next slide. I like to frame this conversation with some different labels and ways we can think about unconscious bias, and we'll refer back to these as we look through our case studies. It can sometimes make it easier to pinpoint and pull out the ways that bias might be at play. So, and this is not an exhaustive list. There are likely other types of biases in the research. So the types of biases we'll use in our conversation today is attribution bias, where we have a tendency to explain a person's behavior by referring to their character rather than the situation that might be impacting that behavior. An affinity or similarity bias refers to our tendency to gravitate towards people similar to ourselves. This one is often discussed in hiring in the way that bias impacts hiring process when companies or organizations or individual hiring managers have a tendency to gravitate towards people that are similar to themselves. Confirmation bias is where we attribute our own bad acts to forces outside of our control and other people's bad acts as indicative of who they are as a person. Or sometimes this can be used to describe situations, as we'll talk about in a little bit with our case study examples, where we are biased towards information that confirms the things we already believe to be true. Halo bias occurs when we perceive one great thing about a person, and then that affects all of our other opinions about them. Opposite of that is horns, where we generalize one negative aspect of a person to all areas of that person or to all people like that person. And then lastly, the prototype bias is where we assume that someone is not the perfect fit for a role or a task based on stereotyping. And I like an example of this. It's a riddle that many of us may have heard, where you have a son and a father who are in a car accident and they arrive at the hospital. A surgeon is taking the son back to surgery and says, I can't perform the surgery. This is my son. How is that possible? Most people would then start to think of explanations such as this is a grandfather, it's a male partner or husband or a stepfather, and we don't necessarily always immediately think that this could be the boy's mother because our societal influences have led us to have stereotypes and preconceived notions about who is a surgeon and what do we think of when we picture a surgeon. And in some cases, it's often not immediately going towards a female. Next slide. So there's lots of impacts of unconscious bias. Some of those are microaggressions. Microaggressions are statements, actions, or incidents that might be indirect, subtle, or unintentional discrimination against members of a historically discriminated community, such as people with disabilities. I have some examples here of things that might be considered microaggressions towards people with disabilities. Things like, I can't believe you are married, or we don't necessarily think that someone has an identity outside of being that person with a disability, or we don't think that they can achieve or are capable of doing the same things as others without disability. We all have some disability, or you're too young to use hearing aids, things that deny the disability experience from an outside perspective. Or you don't look like you have a disability. For those with invisible disabilities, where we typically would think of someone with a more visually presenting disability, this is one they may hear a lot. And then doing things like helping someone with a disability that does not need help, treating people with disabilities like a child, or doing things for them without asking, or we're seeing them as someone who's helpless, or we might be infantilizing people with disabilities by treating them like a child. Next slide. And then there's also more outward ways unconscious bias affects us, macroaggressions, or things that like discrimination and ableism, where things are happening more potentially at a conscious level. Discrimination is the unfair, prejudicial treatment of people and groups based on characteristics such as disability. And ableism specifically is discrimination based on how a person may exhibit or seem to show signs of disability, or based on the way that we perceive or our biases we have towards people with disabilities. So examples of these, and I tried to make these a little more specific to healthcare since that is our topic today. Ableism and discrimination may occur when we have a medical clinic that only has stairs to the main entry of the building, and we have not taken steps for readily achievable barrier removal to make our physical location accessible. It might be someone who flat out refuses to treat patients with a disability simply for that reason, or not providing effective communication for patients with disabilities. One that we'll talk about a little bit more in our case studies is making assumptions about the quality of life of people with disabilities. This was a pretty hot topic early on in COVID, where there was concern about resource allocation when things were kind of in the worst stages of the pandemic, and how assumptions about quality of life by medical providers might impact the care that people with disabilities were receiving. And thankfully, this got a lot of attention to where some policies were rewritten to make sure that these things were not being factored in as a consideration in the decision-making process for healthcare. Next slide. So when we think about biases specific for disability in healthcare, there is a recent study by Dr. Iazzoni that is one that I cite frequently when I present education within my system to our staff and providers, because I think it's pretty eye-opening for people who maybe aren't as familiar with individuals with disabilities or the healthcare inequities for individuals with disabilities. So this study surveyed physicians in a variety of care settings, trying to ask about their perceptions of people with disabilities and how they work with people with disabilities. Some of their findings, this is certainly not everything that came out of that study, but these are kind of the more impactful things. Only half of physicians surveyed said that they, quote, strongly agreed that they would welcome people with disabilities into their practices. More than 4/5 of the surveyed physicians indicated that they think that someone with a significant disability has a worse quality of life than someone without a disability. And only 2/5 of the physicians indicated that they felt, quote, very confident in their ability to provide the same quality of care to people with disabilities that they provide to people without disabilities. So this is something that could be very well rooted in their biases. These physicians likely have biases, conscious or unconscious, around people with disabilities that's impacting both their ability to provide care, but also their comfort and their perception of how they could engage in care for people with disabilities. We'll see how this plays out a little bit in some of our case study examples. Next slide. So now we're going to get into our main focus topic of today, which is diagnostic overshadowing. As Pam said in the introduction, this is an occurrence in healthcare specifically that's really rooted in that unconscious bias. Next slide. So what is diagnostic overshadowing? This is not a new topic. This is not a new thing that we're looking at now. This first came about in the 1980s and was centered around researching why we were missing diagnoses of mental illness in individuals with intellectual disabilities. This idea of diagnostic overshadowing has grown as it has been researched more and applied to other populations. So definitions in the literature really varies. You can see some definitions on the slide specific to individuals with physical illness, learning disability, mental illness. But I think the big kind of catch-all definition is this last bullet, and it's attribution of symptoms to an existing diagnosis rather than a potential comorbid or even new condition. Next slide. So who can diagnostic shadowing impact? It can impact the interactions of clinicians for patients of all ages who have physical disabilities or other pre-existing conditions, such as autism, mobility disabilities, mental health conditions, neurological disabilities, and any other number of pre-existing conditions. Diagnostic overshadowing can also impact patients with other characteristics, such as those with LGBTQA+ identities, individuals with a history of substance abuse, low health literacy, obesity. We're really focusing today on disability, but I mention this because often we don't just have one identity. We are people with a lot of characteristics. So if you think about the fact that this can occur for these other populations, and we have a patient who has a disability plus one of these other characteristics, like low health literacy, a history of substance abuse, it's likely that this could be happening on multiple levels. Next slide. So as we've said, diagnostic overshadowing really stems from that unconscious bias. And this is really only one factor that can contribute to health inequities for people with disabilities or other health conditions. So I'm not here to say that diagnostic overshadowing is the only reason why we have health inequities. We could spend hours talking about all the different reasons that contribute to health inequities. But for the purposes of time, we're going to focus a little more on diagnostic overshadowing today. Next slide. As Pam mentioned in the introduction, there's some potential things that can happen when patients experience diagnostic overshadowing, and this will vary greatly based upon the individual situation and patient and the things they're experiencing. But some examples: their physical condition can worsen. It might result in a decreased willingness on the part of the patient to seek care because they have this experience of feeling like they're not going to be taken seriously. It can have an impact on quality of life if we're not able to treat and improve conditions or things are getting worse. There could be a delay in diagnosis or treatment for these other new symptoms, or potentially unnecessary or unsafe care or treatment if we're attributing to symptoms to the wrong situation and we're not finding the actual root cause. Again, those inequities in care and health outcomes are certainly possible, and in worst case situations, this could even result in death. Next slide. So we're going to go into some case examples. I have 3 different case examples from some different patient populations, just to give an examples of ways that this can occur for people in various settings. So our first case example is in mental health, and this is the same individual, like I mentioned, who had that quote at the beginning of the presentation. This is a patient who has multiple mental illness diagnoses, including borderline personality disorder and a history of eating disorder. She also has a history of migraines and Raynaud syndrome, which is a restriction of blood flow to the fingers and toes, and it's vascular based. So she had 2 situations she described. In this first one, she began having episodes of crushing chest pain, went to the emergency room, or ED. They ruled out a heart attack and suggested that she follow up with a cardiologist. When she followed up with this cardiologist, they said that the chest pain was due to anxiety after, as she describes, they only spent 5 minutes with her in the exam room. Next slide. So then she sought a second opinion because she wasn't very satisfied by saying that it was anxiety and felt that the provider really didn't give enough care and consideration to the symptoms that she was experiencing. The second opinion included multiple testing avenues and really kind of looking for a source of this chest pain, which resulted in a diagnosis of an uncommon form of decreased blood flow to the heart. I will probably pronounce this incorrectly, but we're going to say it's called Prinzmetal's angina. The patient started treatment once this diagnosis was received, and that quickly resulted in a decrease of both the frequency and the severity of these chest pain attacks. Next slide. In another situation described by the same patient, she began to feel frequently nauseated and have increasing stomach pain. Her primary care physician referred her to a gastroenterologist, someone who specializes in our GI tract and digestive system. And that resulted in a diagnosis of functional abdominal pain syndrome, or FAPS. And the provider told the patient that she would have to, quote, learn to live with it. After going home, the patient researched this diagnosis only to find out that it's classified as a somatization disorder, where a person has a significant focus on physical symptoms to levels that result in major distress or problems functioning. Somatization disorders are typically believed to be mental in nature and are often associated with individuals with mental illness and are things that maybe we don't believe that there's an actual root cause to this pain, but it's being exemplified and made worse by the person's mental health. Next slide. So again, this patient sought a second opinion. a new provider began a series of testing and diagnosed a small intestinal bacterial overgrowth. The patient says that it took over a year for her to regain the weight that was lost from having these symptoms and not getting this diagnosis, and even longer to confront the emotional toll of having her eating disorder triggered by this experience. Next slide. So what went wrong for this patient? It likely is that there's biases that attributed to the providers. In both cases, really kind of thinking that there was a mental health cause for these things that had actual physical system causes. There's a huge prominence of stigma and negative stereotypes around mental health, and that could definitely have been in play here. And this also seems like it might be a case of attribution bias, where these providers were attributing these new symptoms to things that they already knew about the patient if they had access to her diagnoses and experiences with mental health. So this was a great example of a patient who was clearly advocating for her needs, sought second opinions when she wasn't satisfied with the answer she was getting, and in doing that was able to receive accurate diagnoses to have her conditions treated. Next slide. Our next case example is one with a patient with an intellectual disability. This is a patient who's a 15-year-old female. She has a moderate intellectual disability, and she's presenting with current complaints of irritability and anger outbursts, but these have been ongoing and worsening for the past year. With her disability, this patient has limited expressive language skills and is predominantly nonverbal in her communication. Throughout the past year, she's become increasingly solitary, expressed irritability towards family members, and was often late for school. Her parents reported observing strange behavioral changes, such as her preferring to be alone in the bathroom for long amounts of time. When they would attempt to increase her punctuality or direct her from the bathroom to other tasks so that way she could do things like be to school on time, that resulted in tantrums, anger outbursts, and even self-injurious behaviors. Next slide. The initial treatment for this patient was focused on the irritability symptoms, and she was given medication to try to decrease this irritability. It, however, didn't work. These problem behaviors continued and resulted in significant caregiver distress on the part of her parents. She ended up being brought to this multidisciplinary team of psychiatrists, psychologists, mental health nurses, people who were a little more experienced at using a structured assessment for a diagnosis, in particular with patients with intellectual disability. This is maybe not common. This might have been a rare find. In this process, they were able to get some additional information from the parents about what was going on. So the parents reported that this time spent in the bathroom was for personal hygiene and that the patient was undergoing repetitive and compulsive washing of her hands. When she was able to complete these actions to her satisfaction, she was calm. But when the parents tried to restrict the behaviors or redirect her to other activities, that's when this irritability would occur. Next slide. So this led to a diagnosis of obsessive compulsive disorder. And when that treatment began, the symptoms got immediately better. They focused on medication at first because there were some limits of being able to engage effectively in cognitive therapy with the patient because of her communication difficulties. But the nursing team provided a lot of psychosocial interventions for the parents and coping skills training for the patient. They saw both symptomatic and functional improvement. So she wasn't as engaged in these obsessive behaviors, which resulted in being better able to be on time for school and to engage in other valued life activities. Next slide. So what went wrong with this case? I like this example because when we talk about things like diagnostic overshadowing and our inclination, if you will, to attribute new symptoms to pre-existing conditions, that's not always on the part of practitioners. In this case, it was the parents who erroneously believed that her behaviors, these new behaviors, were a manifestation of her disability, which is why these things continued to get worse for the course of a year before they began to seek help and to try to figure out what was going on. It's also why they didn't initially give full information, and they didn't really talk about the nature of these compulsive behaviors that then ultimately led to that diagnosis. Similarly, initial evaluations were really focused on the irritability. They saw that as the symptom to be treated. without really trying to assess or ask questions to figure out why is this irritability occurring, and is there a mental health or other type of condition that's contributing to that irritability, which is what we actually need to treat instead of just the symptom itself. Next slide. A little bit more about what went wrong with this case. This is a complex situation, but it's not one that's completely unheard of for those of you on the call who are medical providers or work in the medical field. So there's some definitely challenges with typical assessment processes for someone with communication difficulties and intellectual disability. In this particular case, the specialized care team had experience in this area and had other assessment tools that they were able to use. So that gave them some extra tools in their toolbox to make this diagnosis. Their structured assessment was focused more on the onset, evolution, and context of the behaviors, what made them better, what made them worse, versus just talking about the behaviors at a more surface level. And that's what got them to tease out that information and to make that diagnosis. So you'll see in terms of our recommendations later on, sometimes we need to recognize as medical providers when we might not be best equipped to get to the answer and utilize our networks and referral processes to find care teams like this that might be able to tease out those types of solutions. Next slide. Our last case example is for individuals with physical disability. And this was a qualitative study that interviewed multiple people, and it was focused on how their mobility disabilities impacted the diagnosis and treatment of cancer in particular. So this is not just a one single patient. This is feedback and information and findings from multiple patients. So for one patient, they typically reported that, not for one patient. This was many of the patients reported that their signs and symptoms were not always taken seriously by physicians. And that was due to assumptions in some cases that their pain was an emotional response to their chronic health condition or their physical disability. Patients reported being told that their pain was due to depression, even if they didn't have an actual diagnosis or history of depression. A quote from one patient that I think is pretty impactful is that she had had a colonoscopy, and the provider, who in this case was a high-level senior provider at the organization she was going to, told her, quote, "There's nothing wrong. You're complaining for nothing. This is your 5th colonoscopy. There's nothing wrong with you." And it was 3 days later from this assessment that this patient got the phone call confirming her colon cancer. Next slide. Of the patients that were interviewed, 10 of 20 reported that their cancer diagnoses were delayed due to assumptions that these new signs and symptoms were disability related. And again, in some cases, that was on the part of the patient, not necessarily just on the part of the provider. Patients were again erroneously assuming that these were manifestations of their disability. One patient story, which again is one of the more impactful ones, I think, was a patient with a spinal cord injury who had been losing weight for 2 years. Throughout this process, they were diagnosed with gastroparesis and was told that because of their spinal cord injury, they digested food slower, and that was the issue causing the weight loss. This patient visited the emergency room 5 times over these 2 years, and this diagnosis held, even though they report they were never actually tested for this diagnosis. Eventually, the patient's weight loss became life-threatening, and an x-ray was done to place a feeding tube, which was when they finally found a mass next to the patient's right lung that was stage 2 Hodgkin's lymphoma. Next slide. So again, in some of these cases, we had symptoms being attributed to depression or mental health conditions because there were biases on the providers about the quality of life of people with physical disabilities. So this is kind of an interesting spin on this topic. It's not necessarily that these patients already had diagnosis of depression or mental health concerns, but the providers made an assumption that, well, if you have a physical disability, you must be feeling this way based on what they assumed they would feel, and then attributed new symptoms to that when that was not the cause. In other cases, patients delayed their own care after attributing their symptoms to their physical disabilities. that patient with spinal cord injury on the previous slide is a good example of, I think, of confirmation bias. Here they had in their record that they had this diagnosis. And when they went to see new providers and new cases in the ED, those providers saw that diagnosis and assumed that the symptoms were confirming what they already knew, instead of looking to see if there were other possible explanations or if maybe that diagnosis was incorrect. And we also probably have a little bit of Horn's bias happening here, where people are attributing physical disability as something that's negative and that would result in these patients having depression or mental health conditions or a lower quality of life without actually knowing if that's true. Next slide. So as we saw in some of these examples, patients might also have bias when they come into healthcare, and that could impact their care, whether that's their own attribution of new symptoms towards their pre-existing condition, but there might be other biases that they have that impact the care experience. So I want you to think about a time when you maybe had a less than perfect experience with a doctor or a store or a restaurant. And how does that impact you when you think about returning back to that same place and to that same location? For most of us, that negative experience will stay with us and make us either less likely to return to that exact same location or possibly even other similar businesses that offer a similar service. Maybe it's a chain and they're part of that same chain, and that negative experience results in a bias towards that location. So for some of these patients, and for I think many patients who have experienced diagnostic overshadowing or other biases towards them for having a disability, they might be less likely to seek care when new symptoms occur because of these previous experiences. Or maybe they're going to underplay what's going on, and they might not be fully clear and honest with us about what it is they're experiencing or the significance of these new symptoms. So we have to be sure that we are really teasing out and asking the right questions to get the right information. Next slide. Additionally, they might have other biases that impact engagement with providers that might not even be related to healthcare. We talked in the beginning about how unconscious bias and some of these more negative stereotypes can apply to a variety of individuals from a variety of protected classes. You might have patients who have those types of biases, and that impacts their ability to trust a provider or engage with a provider or be willing to be seen by a provider. And so it's important to acknowledge that this might be impacting, again, that kind of interactive dialogue, especially with a new patient, to try to figure out what's going on and recognize that that could be happening, and then think about different ways we can address that. We had an example in my organization's inclusion committee that was brought up recently, where it was someone who was hospitalized and was working with one of our neuropsychologists, and told her when she walked in the room that she doesn't trust people who aren't of her same ethnicity because she doesn't think that they can understand her life experience and really understand where she's coming from as a patient. When things like that happen, we want to try to meet those patient needs and see if we have other individuals within our system we can refer them to so that there can be that trusting relationship in the care. And the same could be said for individuals with disabilities. If they've had a very bad experience with a certain provider, let's get them referred to someone who maybe has more experience and comfort or has had more success in working with patients with a specific type of disability. Next slide. So now we're going to get to kind of the big juicy meat of the conversation, which is what can we do about this? So we know that this exists. We've seen some examples of some pretty not great situations. How do we stop this from happening? Next slide. The first thing we have to do, and I think we'll all hopefully walk away with this from today, is acknowledge that diagnostic overshadowing exists, and its occurrence is both widespread and can be very serious. So there's lots of ways that we can do this for those of you who are healthcare providers or work in the healthcare world. If you're doing any sort of clinical peer or quality assurance reviews, reviewing specific cases or outcomes or data, keep this in mind as you're evaluating these cases and see if diagnostic overshadowing or other bias may have contributed, especially if there was an adverse outcome or a patient who was unsatisfied with the outcome, and then bring that up and pose that question and get folks thinking about if this is something that was at play. Next slide. As I said before, we were going to talk about what do we need to do to address our own biases. So again, Everyone has biases, even if you think you might not in areas that you feel pretty confident you don't, you still may. So there's some tools out there, and I've included some links here to help us reflect and increase awareness of our own biases. And I want to preface this with, this is not an easy thing to do. This is hard work to really take the step to reflect, to think about the ways in which we might have biases and how that might impact our daily lives. The Rocky Mountain ADA Center has a training that is about managing implicit bias. There's another link here for Project Implicit through Harvard University. Both of those will engage in some different assessment to help you realize maybe ways that you might have biases. And when you go into doing these, if you choose to do them, it's not going to come back with results saying like you are biased against people with disabilities. It's going to be a little more nuanced than that and say you demonstrated a tendency towards a bias in these situations or in these contexts, and it gives you a little more information. There's some great courses and videos in LinkedIn Learning if you have access to that at all. I had hoped to link some or include some in this presentation, but I couldn't get the video to embed. But if you search for unconscious bias and some of the other terms we'll review here in a little bit about upstander training, there's some fantastic videos that really talk about how to do this work and how to reflect and how to think about things in your own life experiences and how they may influence your decision making. And in the interest of being fully sharing, I'll give you an example of when I kind of realized some of my own bias. I have been working my entire professional career with individuals with disabilities, advocating for them, helping support them to meet their life goals, both in healthcare and in other areas. And a couple of years ago, when I finally started to acknowledge that I was having issues with hearing, it was hard for me to take that step and to actually get a hearing test, think about getting hearing aids, and take that step to acknowledge that something wasn't working right for me, even though this has been the vast majority of my adult life that I have been in this arena and in with these populations. And when you have to apply it to yourself, sometimes it gets a little bit harder. And it made me realize that even though this is the work that I do, I was still influenced by society and biases towards hearing loss. And who do we think of when we think of someone with hearing loss? It might not be somebody like me who was in my mid-30s at the time, but it's been a huge help and it's made a huge difference in my life to use these hearing aids. So think about examples like that, even for yourself, or maybe something didn't pan out the way you thought. And when you reflect on it a little further, it might have been rooted in a bias, unconscious or otherwise. Next slide. I am not used to talking for this long. I apologize, my voice is getting cracky. So once we build awareness of the impact of bias and diagnostic overshadowing, it can just make us more likely to recognize when it's happening in ourselves and in others. So it'd be very easy for me to sit here and say, if you see bias happening, call it out and make sure it stops. But that's also a very hard thing to do. So I want to give you some tools about how you might be able to do that. And if you can practice them and think about them when it's not in the moment when something's occurring, it might help us feel more prepared to act in those moments. And there's a link here to a resource from Johns Hopkins called Calling Out versus Calling In that describes some specific types of scenarios and gives some specific scripting that you might be able to use in those scenarios. Next slide. So when we think about confronting bias, there's this concept called being an upstander. So you may have heard of some of the well-known studies about something called the bystander effect, which is where we may be less likely to act in a situation when others are around because we assume that someone else will respond. A lot of the popular research in this area is around situations where something pretty significant is happening. I remember learning about one where someone was getting mugged on the street and people were not likely to call for help or call 911 because they assumed somebody else was doing it. But this can also occur in situations that you wouldn't necessarily think are quite as significant. There was again, a training video I'd hoped to show you that I couldn't link in through LinkedIn Learning, where they set up something to be like a product demonstration. And somebody was just setting up a tent. And they did this in different phases. So in some phases, they had groups of 10 or 15 people. Some it was a group of 5, some it was just one person. When it was groups of people, all but one of the individuals was in on it and was an actor. And the person who was setting up the tent was really struggling with the process and taking a lot longer than you would expect it to take for someone to set up a tent. And they timed how long it took that one person that wasn't in on it to offer help or to act or to say something. And that time significantly decreased when there were less people around, to where when it was just the person by themselves, it sometimes only took a couple of minutes for them to offer help. Or when they were in a group of 15 people, sometimes it took 10 minutes for them to offer help. So bystander effect can happen in a lot of these types of scenarios. And this idea of being an upstander is a challenge to that. Someone who takes actions in these situations where the bystander effect is likely to occur, such as when we might be seeing outward bias, microaggressions, discrimination, or diagnostic overshadowing. Next slide. So what does it mean to be an upstander? This training is often accompanied with 3 Ds of intervention, 3 different approaches we can take in these situations. And you might use some of these interchangeably. You might use more than one in a situation. And I like it because it's not all set up to be confrontational in that moment. Some of these are things you can do after the fact, which might be more comfortable for some of us or in some situations. So the 3 Ds, directly challenge something in the moment or not in the moment, checking in with that person who was the subject of the bias to see if they're okay. So an example of this might be if you're in a healthcare situation and you're maybe not the main provider, but you're involved in the clinical decision-making, you might say, I don't think we should assume that these symptoms are related to the patient's disability without exploring other options first, if you think you might be seeing signs of that diagnostic overshadowing or that bias towards that pre-existing condition. One of the other Ds is delegate. Tell someone else who can help intervene, such as a supervisor or a person with authority. Depending on the situation, sometimes there's power dynamics at play to where there could be actual repercussions if we were the one to directly act in that moment, and we want to recognize that. And then the 3rd D is distract. Interrupt the situation or redirect to the individuals who might be at risk. So sometimes you might, like I said, you might use all 3 of these. With delegate, sometimes that might also be if you're the patient, you might delegate that to the clinic manager after the fact. Sometimes we reflect on things when we're done with an appointment and then we realize, I don't think that went the way I wanted. I'm starting to realize maybe there was some bias. Let me take that back to the manager of this clinic or this organization so they can help me navigate what to do next. And we'll talk a little bit more about how to utilize these as a patient in a moment. Next slide. So again, for healthcare providers, when we're doing that assessment and really looking for a diagnosis, this is, I think, where we can have the most strategies to implement to try to combat diagnostic overshadowing. So like we've talked about with some of these case examples, using techniques that are designed to gain better patient engagement in a shared decision-making process. Try to ask open-ended questions, not just yes, no questions. Ask questions to really dig and get more information. It's also important to pay attention to nonverbal communication. What's the impact of the environment or the physical setting on communication? And think about the context of the nature of the visit as well. If you're working in an emergency room or in urgent care, where we typically see patients with emergent and new and often very painful situations, they might not be able to communicate as well as if it's a routine physical at your primary care provider. As we've said many times so far, don't make assumptions about a person's quality of life or assume that that quality of life is lessened by these pre-existing conditions. And then we want to be sure we're assessing all aspects of health and wellness as potential root causes for behavior, not just thinking as something changed with this pre-existing condition that's now causing this. Has anything changed? Next slide. And again, like we've said, seeking help from outside providers, but also from that patient support network. We want to be sure we can understand the patient, how to communicate effectively with them, and to get a better sense for baseline behavior and changes in behaviors. So if you think back to that example of the patient with the intellectual disability, it took a while to really tease out what was the change in behavior and what was the cause of that change in behavior. Instead of just saying, well, she's been very irritable, we had to tease out those specifics to figure out what was actually going on. Utilizing those interdisciplinary teams when we can for these patients with complex needs, as we saw in that example, it can be critical and key. And then I can't talk about disability in healthcare without a plug to document disability-related needs and accommodations in our patients' charts and electronic health records. We as providers cannot know what patients need and implement what they need if we don't know and don't have it written down that that's what they need. For a system such as mine, where we have lots of providers that share that electronic medical record, we want to be sure we document something that was super effective or an accommodation need like effective communication. So that way it can be used in other settings and the patient's not having to continually ask for it and continually face that burden, because that could then impact how often they're coming into our spaces. Next slide. So this is a video that really, I think, expresses these concepts we're talking about. So this is a provider who's meeting with a new patient for the first time and asking these types of open-ended questions to get to know the patient, but to also build that trust and to facilitate that positive relationship. I'll caveat this patient before we, or this, not this video before we start. The doctor in this video is a real doctor. This patient is an actor, so they do not actually have the condition in which they are talking about, just so you know. Go ahead and play.
Ian is a 55-year-old male T10 paraplegic with metastatic pancreatic cancer. He's being treated with third-line chemotherapy. Recent staging scans show disease progression. Ian's oncologist is unavailable due to an extended medical leave. Therefore, a covering physician will be meeting with Ian virtually to disclose the results of the imaging studies and discuss his treatment options.
To be honest, I'm terrified, and I'm trying to remain hopeful. I'm not expecting the best news. I'm never eager to go see a provider, especially one who I don't know.
Ian, hi, my name's Katie Stowers. I know that usually you meet with my colleague, and so I appreciate you being willing to meet with me today. You know, your doctor told me a lot about the medical side of you, but I would really love to learn a little bit about who you are as a human and as a person.
Yeah, that would be great.
Tell me a little bit about who you are and what you think is important for me to know about you as your doctor.
So I'm a rapidly aging middle-aged guy with a family and a useless dog and all sorts of stuff, and I've a bucket list that is not complete.
And I'd love to explore the bucket list with you in a little bit more detail. I'm curious if you could tell me a little bit about what day-to-day looks like for you.
I get up early, and I'm trying to get back into exercising. That's been a big part of my life since forever. And I'm just trying to live each day and do the most fun stuff, most meaningful stuff I can. My wife and I have a teenager, some call them. So I like to try and help out in the kitchen, trying to get back into full-time work. A doctor once said, do you work to live or live to work? I'm working to live.
Wow, Ian, I can tell there are so many aspects of your life that you have such passion for. And I'm curious if you could share with me some of the other things that bring you joy in your life.
We like to ride bikes and get out and try to be active. And my extended family is very important to me. I've become pretty much a homebody, but prior to that, we travel a little bit, and we've got some trips we still want to make.
And I appreciate you allowing me to have a little bit of a sneak peek into who you are outside of the medical record, which is the only peek that I had into you before. But I'm wondering if there's anything that you feel like I need to know about you as the doctor to be able to help care for you as best as I can.
I get the feeling that I'm important to you, and I haven't always had that experience in the healthcare realm.
Well, Ian, thank you for sharing that. And I'm sorry that your experience with the healthcare system hasn't always been as positive as it could be. I think that's really helpful for me to know. If it's okay with you, maybe we'll switch gears a little bit and talk about the CT scan and where we go from here.
I tried to impart on Dr. Sowers that my life was full and that it was important. And I could tell by the way she responded to particular things that I said that she understood, and that made me believe that it was important to her, that nobody was going to receive better care from her than I did. I never have to doubt a provider who I trust. I never have to ask myself, would I have received different care if I didn't use a wheelchair? When I trust a provider, I can think about the treatment, I can think about getting better, I can think about recovering. And I don't have to worry about, I don't have to spend any energy at all wondering if I'm getting their best.
I saw a comment in the chat about not being able to hear that video very well. Apologies for that. If you download the presentation, at the slide in the one with the other video, that is a clickable link that will take you to the video in YouTube, if it's something that you would like to refer back to or watch again. Next slide. All right, so some additional strategies for patients. We've talked about this a little bit throughout, but the biggest thing I want to encourage you, if you are a patient with a disability or with a different type of characteristic or protected class that you think might be factoring in with bias or unconscious or diagnostic overshadowing, if you feel like that's impacting the care you're receiving, the best thing you can do is let us know. And I know that that is so hard to do. So I've reworded that phrase from our slide on upstander training about the direct approach in terms of how you might be able to say something in that moment if you feel empowered to do so, which is, I don't think we should assume that these symptoms are related to my disability without exploring other potential causes first. Again, a lot harder to do in the moment than it is to talk about it right now. So feel free to use that too if you really, upon reflection, or feeling like that after the fact and you want to follow up with that provider, send them a message, give them a call, and to convey that information. As we saw in our first case study example that was centered around mental health, seeking second opinions when you're not satisfied with the care that you're receiving can sometimes be pretty impactful and even life-changing if you find a provider who's better able to meet your needs. And the biggest thing that I would like to communicate to our patients on the call today is to give those experiences and feedback about your experiences back to that clinic or organization. So if it's a larger healthcare organization, not just like a single privately owned office, they very likely have someone who's in my role, either as an ADA coordinator, it might be called Section 1557 coordinator. That's part of the Affordable Care Act and is the non-discrimination clause of the Affordable Care Act. People aren't always going to know who we are or how to find us. So your easier route to get to us would be to reach out to the manager of that clinic or ask how you can get in contact with a patient representative. Patient representatives are folks within our organization, at least I know within mine, they're all clinical. I think all of them are nurses and have worked in a clinical capacity at some point before, and are the ones who receive these patient feedback, complaints, good things, bad things, and then escalate that to next steps as needed. So they might be the ones that if it's a pretty significant situation and you want to file a grievance, you would start with them. But they would know who their ADA coordinator is or who within their organization has a little more experience and expertise in disability and the ADA requirements and other things to where they can get you connected with that person. And I saw the comment about the hearing loss community being reluctant to request accommodations, don't know what to request or when or how. This might be the best contact for some of those patients to reach out to if they're struggling with that process. Get connected with a patient representative, with an ADA coordinator, so you have someone to help navigate that with you. Because like I said, my role is fully focused on patients and making sure that our patients are having their needs met, receiving equitable care, or receiving the accommodations that they need while they are in our clinics. So sometimes I don't know what's not going well if I don't hear from patients to know what we need to work on and to fix and to educate or to provide if we don't have it. So please feel free, feel empowered after this conversation today to make your voices known, make that feedback known, even if it's something good. We always like to hear the good things too, but if it's something that's not going well, let us know. Next slide. That is all the content that I have for you today. I tried to go really slow and we still have quite a bit of time left for questions, which is good. I do have a number of slides at the end of this presentation as well with the references and links to some of those references. So feel free to look at those if you would like some more in-depth information about some of what I shared with you today.
Well, Holly, thank you so much for providing this excellent information. Folks have been very appreciative in the comments, and for some, they said it's the first time they've ever heard this information being shared from specific to the healthcare arena. So this is very exciting. Folks, we do have time for questions. And so what we would like for you to do is, if you have a question, please put it in the chat area. And I will be monitoring that for you so that you can, I'll be monitoring the chat area and we'll read the question, and then we will give Holly the opportunity to respond. So in the meantime, we do have one question that has come in, Holly. So it says, how do you see the concept of noise? And then in parentheses, Daniel Kahneman, so interacting with diagnostic overshadowing, and is it something being factored into these conversations as a separate yet related contributor to these situations?
So I would like to ask a question back because I'm not sure if I know exactly what it is you are referring to with this question, Cody. Can you explain the concept of noise a little bit more for me, just to make sure I'm answering correctly if it's something I do know? I feel like it's deeper than just environmental noise, so I would like some more information, please.
All right, and we do have another question. It says, maybe later in the presentation slides, do you have links to the case examples or case studies that you provided?
I do. So there are like 5 slides of references. If there is one of those in particular that you are gravitating towards and you want that specific one, if it's not evident by, this is like the formal APA format for our references, I can direct you to which one it is specifically. And as we go through this, if you go one more slide, I can point them out if I see them and if I remember. So the first one on the slide, what number slide is this slide references for, is slide number 51. The article was called Diagnostic Masking and Overshadowing in Intellectual Disability. So that's where that intellectual disability case study came from. The last one on this slide, my experience with diagnostic overshadowing, was the mental health case study and quote at the beginning. And I don't remember off the top of my head which of these was the physical disability one. It might be, I think slide 49 references to the first one there. But I can double check that. So if anybody would like those articles in particular, let me know.
And Holly, just so you will know, Cody said he'd be happy to, talk with you at a later time about the information, if that would be acceptable.
Absolutely. I want to know more about all of the things. So if there's something related that we might need to take into account as we're doing more awareness and training about these concepts within my organization or outside of it, I would love to know more about that.
All right. Again, if you have any questions, please put them into the chat area and I will read them aloud so that Holly can respond. So we'll give you a couple of minutes to do that in case anyone has a question you haven't had the opportunity to ask yet. We do have a question. It says, are the digital charts standardized? Is there a way to have my disability hearing loss noted front and center of the chart? I wish.
No, they are not standardized. So, and it's so unfortunate. There's different companies that make electronic medical records. One of the more popular ones is Epic. So you may have heard of Epic. That's what my organization uses. And even within that, organizations can customize the medical record specific to their organization. So even different organizations that use Epic might not have it set up the exact same way. What I will say is that there are a lot of initiatives around documentation of disability status, and there's people working for organizations like Epic in particular that are really focused on this and are looking at it from that health equity standpoint. So trying to find ways that we can make it more prominent, that it can be more available to the staff that needs to see it. Because if it's in the chart, great, but it doesn't do us any good if the staff don't see that and see what those needs are, to know then what to do and what to offer that patient. So I'll try to describe a visual of how it is with our view of Epic. When someone opens up your chart, there's a little like screen along the left side that is kind of all that key patient information. It has your photo if we have one, and there's one part of it that says disability needs, and it will say yes or no. If something's put in to that field, it will show what it is there, and you can click it to get more information. But then staff have to know to look for that. So as much as I would love to make this a more universal, easier thing, it's bigger than just me. And there's a lot of work happening though to that effect at some national levels and within the electronic health record organizations. So the unfortunate thing is that even once it's documented as a patient, you still might have to mention it or let people know this is documented in my chart. This is what I need for them to be able to find it. I'm hoping at some point we will have a perfect world where that's just all automated and it pops up right in their face and people won't have to continue to ask for those things.
Right. Thank you so much. So actually we have another question / comment, and hold on just a moment. I've got to get back to it. As you mentioned that your hospital organization likes to cater to patient desires based on lived experience, e.g. the patient who only trusted providers of the same ethnic background. How do you draw the line between not wanting to traumatize a patient, but also not discriminating against hospital employees based upon their own identities? For example, if a patient did not want to work with Black professionals, would the hospital system grant that request?
That is a fantastic question. So it's a very gray area, right? There is typically no hard and fast line to draw with some of that. And a lot of it will depend upon the specific circumstances of the treatment, the providers we have available, and kind of the whole picture. So for that example I mentioned, where it was someone who didn't want to work with that neuropsychologist, we don't have a neuropsychologist in our system that is the same ethnicity as that patient was, because you think about the societal impacts on bias. A lot of these fields, we are typically underrepresented from individuals who are not white. So finding a provider that would meet that need sometimes is just not feasible. The take-home message and the fundamental thing for us as healthcare is we cannot and we will not delay care in a way that would be detrimental to a patient to meet one of these requests or needs. So if somebody is expressing those types of biases, we wouldn't wait for someone to be available to provide that care if it's a high need emergent situation. Our organization, and I think a lot of healthcare organizations right now as well, are really trying to do a lot of work in this area of bias and inclusion and equity. And so we have rolled out a number of trainings, including a full training on just that upstander concept for our staff to help bring awareness to these types of interactions and provide those types of upstander tools in the toolbox that we can use when we're faced with a situation like that. So even in this example I gave, the patient expressed that concern, but it didn't mean then that neuropsychologist did not then work with that patient. She did. She heard what the patient said. She acknowledged it. She acknowledged that she might not have the same understanding, and then explained the ways that she's still there to help that patient and try to meet her needs, and was able to form a bit of a trusting relationship to meet that patient's needs. So that's kind of the approach we would try to take. We want to hear and honor those things, but not necessarily always give in to them if it would be detrimental, or in the case you said, if someone didn't want to work with someone who was Black and it was an outward like racist statement, we have ways from that upstandard training that we're hoping our staff will use to mitigate that in the moment, or get their supervisor or somebody else who's a little higher up in the chain and a little more experienced to help manage what that patient's asking for. So I hope that answers your question, because yes, we don't want to open up the reins to you can request everything specific about your provider, because that just might not be possible.
Right. We have another excellent question. It said, I've seen the names like ADA coordinators in hospitals. However, lately I've started seeing other terms that are similar to ADA coordinators. What are some other names we should be aware of when we reach out for ADA coordinators at hospitals?
Great question. So it will vary. It could be accessibility coordinator. It could be, again, and we can pick this in the chat if it helps, Section 1557 coordinator. That is part of the Affordable Care Act that at one point required healthcare organizations to identify someone as being in that role and make their contact information available. That requirement has changed as the Affordable Care Act has changed over recent years, to where I believe currently it's not currently a requirement that someone has that designation, but a lot of organizations will have that designation. And if you're not sure about a job title to use, that's when I would say reach out to the patient representatives and say, you know, this is my concern. I have a disability. I'm trying to get my accommodations and my needs met. Who in your organization has more expertise in supporting people with disabilities that I can talk to? And that might cue them to find that person if they're not identified as an ADA coordinator.
Thank you. Someone is interested in knowing more about your job role and where did you get your ADA education?
Oh, that's a great question. So I think the nice thing about this type of a role is there's a variety of education and experiences that someone could have that would make them succeed in this. So I, by training, am an occupational therapist. I did my master's degree in that a number of years ago, and happened to find this position because my previous role, I was doing a lot with supported employment and supported education. And that's how I kind of learned more about the ADA and kind of got really interested in it. So when I knew I was ready for a change, I started searching for ADA coordinator roles, which is how I found this. That's certainly not a background everyone needs to have. There's 3 other ADA coordinators in my organization. We split things up. One of them is also an occupational therapist, and the other 2 don't have that background. One has been a ASL interpreter, and the other started with interpreter services and then moved into this role a number of years ago. There is a training, an ADA coordinator certification training that you can do. I'm guessing, Pam, you probably have a link or information about that more readily available than I do. But I did do that certification when I started this role, and that's focused on the ADA as a whole. And ADA coordinator is a role that's present not just in healthcare. State and local governments are required to have ADA coordinators. A lot of large employers will have ADA coordinators on the employment side of things. But it's a obviously I love my job if I'm here talking to you and so much about it. But it can look different depending on the role, and the experience that would fit that would depend on the organization and the role. But I think having experience working with the disability population and folks with a variety of types of disabilities, so you understand how that impacts their ability to engage in healthcare, is pretty key.
All right, and I just put the link for the ADA Coordinator Training Certification Program offered by the University of Missouri in the chat area, and that's adacoordinator.org. All right, so we've got a couple of more questions here. And this one says, how common is psychosomatic illness? I know a lot of people with mental health issues, especially women, are not taken seriously because of physical symptoms that are overly attributed to mental health issues. How does someone know if it's physical or psychosomatic?
That is a great question. So, and I'm glad you mentioned that, because I had meant to caveat that when we talked about those somatization disorders, which is not to say that that's never actually the case. There are genuine cases where it's something that's manifesting and as pain, but is not rooted in more of a physical structure or system of your body. So it does happen. How frequently it happens, prevalence, I'm honestly not sure because I'm not a mental health professional. But I think the key thing, as if you're coming as a patient, and you mentioned women in pain, very true. It's even less likely to be taken seriously if you are a woman of color in pain. So if you've received one of those diagnoses and you're not sure it's accurate, that's where I think things like getting that second opinion, reaching back out to maybe your primary care provider, if you have a good one who you trust and who you like, to explain the situation and see what other suggestions they have. Because there might be cases where it is accurate, but there are also, as we have seen, are cases where it's not. And so just trust your gut and trust what your body is telling you and what you are feeling. And sometimes it might be something that for some people makes sense. And then if they move more towards a mental health treatment, getting with a good therapist or psychiatrist or psychologist to help explore the root causes of that, for more of that mental health perspective will work. But that's not always going to be the answer for everybody. So that's only like half of an answer to your question. And I apologize, I don't know more, but I'm glad you called that out, that those are genuine things that do happen sometimes, but that doesn't mean it's all the time to every person with a mental health condition.
All right, we have another question. It says, what are our patient rights to switch providers or fire a provider if they're not really providing good care, especially when the system has the policy that people cannot switch providers in the same practice because everyone is equally skilled?
That is an interesting policy that an organization has. I don't know that our organization has a policy like that. I would say that as a patient, you should have that right to change providers, especially if you've had a very specific negative experience that is driving that. Now, that doesn't mean, let's say if it's a primary care practice with multiple providers and you want to switch the person that's your designated primary care provider, that doesn't necessarily mean then that the health system will be able to guarantee that that's the only person you're going to see for every appointment. Because if you have something kind of urgent or emergent, and you're trying to schedule same day, that provider might not have availability. And so they might schedule you with somebody else. And it would probably not be possible or feasible to always have availability with that person. But you should be able to designate who that primary person is and who your primary care provider is based on some of those preferences or experiences or interactions. So that's where if you've been told that they have a policy where you can't do that, I would reach out to a patient representative and voice your concerns about how that policy is impacting your ability to engage in healthcare with that system or with that office, and ask what your options are and what you can do. And they might be the better person to help you navigate that on the internal side.
And I would also encourage you, if it's a person that has either Medicare or Medicaid, then there's also a Bill of Rights under those health plans. And so that's another place where you can explore that. And each state has an office that manages their Medicaid. And then there's the Center for Medicare and Medicaid Services at the federal level. So, all right. So I believe we have time for one more question. And so it says, I feel that the mentally challenged happen a lot to homeless, and they are often overlooked. They are taken in and then released, saying to come back the next day or even a week later when they clearly need help right then. So is there anything we can do about this?
So an important thing I think that relates to this, and especially if someone's coming into an emergency room in particular for care, is there is a law called INTALA. And I should be able to tell you what that acronym stands for off the top of my head. And I probably am not going to remember right now. It's EMTALA. It's Emergency Medical Treatment and Labor Act, I think. And what that says is for organizations to which it applies, which isn't going to be every single healthcare organization. For sure, if an organization accepts Medicare or Medicaid, INTALA applies to them. That is a requirement that if someone comes into our emergency rooms with a life-threatening condition or a condition that needs treatment, we cannot discharge them until they are at a stable place. So we have to assess and find the cause and provide treatment before we discharge them. That law also says that we cannot ask questions about insurance or someone's ability to pay as a condition of providing that treatment. So for someone like what you're mentioning, who is maybe part of our homeless or unhoused population, who doesn't have insurance, who doesn't have the financial means to pay for this appointment, legally that can't influence how they are treated medically. They still need to be given the same care and the same treatment to reach where they are considered medically stable before we are discharging them. There's definitely some complexities there because this is a population who's less likely to have a primary care provider that they can then follow up with. And so if they're going to have follow-up care, it's likely to be right back into that emergency room, right? So just know that EMTALA is a law. It's one that unfortunately there's lots of violations and citations for, and things don't always go as well as we want it to from a legal perspective. But if you happen to know somebody or live in an area where you know this is happening, or you know of a situation where you feel like somebody was not brought to that medically stable place before they were discharged, you can raise that concern with the organization itself or with your state medical board, or your state Medicare office is a resource to go to for that as well.
All right, so let me check. I think we are. And this is just a follow-up comment. It says often our Medicaid patients are pushed to the end of the line and often wait for hours for help at our local hospital. And then when they are released, they often are expected to walk miles, being very ill in the middle of the night. So, yeah.
If you happen to know those patients, see if they can advocate for maybe getting connected to social work. A lot of organizations will have social workers that can help connect them with resources, or make sure that we're not turning patients away to an unsafe situation that's going to make their health outcome worse. That's not ideal for anyone. That is very unfortunate to hear. I wish I had more answers for you for that. It shouldn't be happening is the bottom line.
Right. And I did just put some basic information about EMTALA, EMTALA, in the chat for you, and it's some about the rules and regulations. So, all right, folks, well, we are nearing the top of the hour, so we are going to wrap up here. We know that some of you may have had questions for our speakers and that we were not able to get to. However, you can contact the ADA Center at 1-800-949-4232. That number will route you by your area code to the ADA National Network Regional Center that serves your area. You will receive an email with a link to the online session evaluation for today. So if you can please complete the evaluation for today's program, we do appreciate your input and do take it very seriously. I want to thank Holly again for her presentation and for her time to answer the questions. Her knowledge has been valuable. And so we want to make sure that you also know that today's session was recorded and it will be available for viewing next week at www.adapresentations.org/archive.php. Thank you today again for attending the session, and wishing you all a wonderful day. Thank you.
Great. Thank you guys so much for all of your help and facilitation. That went very, very well.
Oh, I was very impressed with your presentation. It was phenomenal.
You know, I've done a shortened version within our organization like 2 or 3 times already this year. So it's a very, very hot topic, I think.
Yeah.
So I'm glad that we had some good attendance and great questions and good feedback.
Yes, definitely. Definitely. So, all right, Gabriel, anything else you need from us?